Perceive, process, perform. Do you need inspiration for your practice? Or do you simply need to practice inspiration? With this series, we aim to do both. Give us 15 minutes and we'll give you practice inspiration. Dr. Bill Robbins has developed a systematic approach to looking at complex interdisciplinary patients. In this presentation, this 2010 SSC Award winner shares an overview of his comprehensive method of diagnosing patients.
My name is Bill Robbins and I'm from San Antonio. And I'd like to bring greetings to all of you from my beautiful little hamlet in South Texas. This is where I live and practice. The title of my presentation today is 456 Global Diagnosis. Global diagnosis is a systematic approach to looking at that more complex interdisciplinary patient. My partner Jeff Rouse and I have been working on developing this system for the last 18 years. It turns out that there are only 4 global diagnoses that dictate all interdisciplinary treatment planning. First is related to the upper lip. Second is related to the clinical crown length. The third is dentoalveolar extrusion, which means the teeth have super erupted. The fourth is a skeletal discrepancy. It turns out that there are only 5 things as a dentist that we can fix. And that's the reason that this dictates all interdisciplinary treatment planning patients. The first is the landscape with an emphasis on the upper lip. The second is a short clinical crown. The third is a dentoalveolar extrusion, and the fourth is a skeletal discrepancy. Let's start off with the first thing that we can fix, and that is the lip. We remember that the average lip length in the young female, when I say young, I'm talking about 25 to 30 years of age, is 20 to 22 millimeters. Young males, 2 millimeters longer. So we look at this young woman who has excess gingival display, and we look at the measurement of her lip, and it's only 18 millimeters long. That's the etiology of her gingival display. It's a short upper lip. The other possibility is a hyperactive upper lip. And we know from our literature that the average lip mobility is 6 to 8 millimeters from repose to full smile. So here's a young woman whose lip translates 10 millimeters from repose to full smile, and that's the etiology of her gummy smile. Once we make a diagnosis of a shorter hyperactive upper lip, our treatment today is Botox. So here's a young woman that has a couple of things going on, but one of them is a short upper lip. Her upper lip measures only 18 millimeters. So we're going to administer the Botox at the ala on either side of the nose, and about a week later, when it has the time to take its effect, that's her maximum smile. And no matter how dirty the joke you tell this patient, that's as high as her lip can go. It's a wonderful treatment for this subset of patients that have short or hyperactive upper lips. So the first thing we can fix as a dentist is the upper lip. The second thing we can fix is the tooth. We remember the average central incisor is 10 to 11 millimeters long, and as dentists we've become very adept at taking short teeth and making them anatomically correct with porcelain restorations. So the second thing we can fix as a dentist is the tooth. The third thing we can fix is the gingiva. So here's a patient that has significant excess gingival display, and she has a diagnosis of altered passive eruption because her front tooth is very short when we measure it, and also we cannot feel the CEJ in the sulcus. So we're going to do the aesthetic crown lengthening procedure on her, and there she is before and after with a significant difference in her smile. So the third thing we can fix as a dentist is the gingiva. The fourth thing we can fix is the alveolar bone. And most commonly, we're going to be dealing with the alveolar bone in the patient that has dentoalveolar extrusion. That's the patient whose teeth have super erupted and taken bone and soft tissue into the incorrect places. On the upper diagram, we see the normal gingival line. When we draw a line from canine to canine, the central should be on that line in the beautiful smile. In the lower diagram, we see the patient with dentoalveolar extrusion. The upper teeth have super erupted, and as they super erupt, they bring bone and soft tissue with them. Now, I'm showing you this in the maxillary anterior region, but dentoalveolar extrusion can occur anywhere in the mouth. Upper jaw, lower jaw, front teeth, back teeth. So here's a patient that has dentoalveolar extrusion. We can see the gingival line is curved or concave due to the wear of the maxillary central incisors. One way to treat this patient would be to orthodontically intrude those teeth, but he's chosen not to have orthodontics done. So we're going to deal with the alveolar bone in this patient. So we're going to go in and do functional crown lengthening, which is different than aesthetic. We're going to remove bone 360 degrees on this tooth using the instruments that are created for the functional crown lengthening procedure. And once the bone has been leveled and the gingiva has been replaced, the tissue will heal at a level. So we draw our line again, and we can see post-op, we now have a good gingival line as it's supposed to be. We then go in and put our anatomically correct restorations on the teeth. So the fourth thing we can affect as a dentist is the alveolar bone. The fifth and final thing we can fix as a dentist is the skeletal part of the patient. In other words, the skull bones. And the discrepancy that impacts me most often in my practice is the vertical discrepancy. That's the patient who has a long face, vertical maxillary excess. So we look at a patient's facial proportions and we see that the middle and lower thirds should be 1-to-1 in the proportional patient. In the patient that's got vertical maxillary excess, the lower third of the face is longer than the middle third. The treatment on these patients is orthodontic surgery. A piece of the maxilla is removed and impacted, and you can see there's rigid fixation. Commonly, a lower jaw procedure also has to be done, and it's a 2-jaw procedure. So here's our patient with a long face, excess gingival display, and when we look at the middle third and the lower thirds, we can see that the lower third is significantly longer than the middle third. So our diagnosis on this patient is vertical maxillary excess. You'll also notice that she's got a convex facial profile. So we're going to do a maxillary impaction and a mandibular advancement. And there she is before and after her 2-jaw surgery. A very nice result, but a serious surgery. So at the end of the day, there are only 5 things that we can fix as a dentist. And that's the reason these are 4 global diagnoses that dictate all interdisciplinary treatment planning. So the 4 of the 4, 5, 6 global diagnoses are the 4 diagnoses. The 5 part of it is the 5 core questions. And this is the magic in our system. All a clinician has to do is to ask and answer 5 questions to determine a global diagnosis on any patient. So here they are. Face height, lip length and mobility, gingival line, tooth length, can you feel the CEJ? They're the norms. And these are norms that you just have to memorize. They're very simple to memorize. And once you know the normative numbers, then you can determine why the teeth and gingiva are in their incorrect places in any given patient. So here's how the system works. On the upper diagram is the ideal. On the lower diagram is the problematic patient. So we'll go through and ask the 5 questions. There's the problem right there, face height. That's supposed to be 1-to-1, and yet in this patient, the lower face is much longer than the middle third of the face. All of the other numbers are normal on this patient. So our diagnosis on this patient is vertical maxillary excess. So remember, if a patient presents with a lot of gingival display and the lower third is significantly longer than the middle third, the presumptive diagnosis is vertical maxillary excess. However, the lower third can be shorter than the middle third. And in those patients, it's vertical maxillary deficiency. And the treatment for that patient is orthodontic surgery. And then, of course, the final discrepancy is the AP discrepancy. And that's a patient with a Class 2 or Class 3 malocclusion. And again, the treatment for these patients is either orthodontic surgery or orthodontics. This is the skeletal component in the global diagnosis system. Okay, once again, the top is ideal, the lower is the problematic patient. She's got normal looking teeth, but she's got gingival display. So let's go in and ask the questions. Her face height is normal. There's the problem. The problem is that she's got a short upper lip. Gingival line, tooth, CJ are all normal. So her diagnosis is a short upper lip. The patient can look exactly the same, but have a different diagnosis because in this patient, it's not a short upper lip, but rather a hyperactive upper lip. Once you call it a short or hyperactive upper lip, the treatment, as we know today, is Botox. Here's another one. Top is normal, lower is problematic. We can see that this patient has the concave gingival line. So let's go through and ask the questions to confirm the diagnosis. That's normal, there's the problem. The concave gingival line from canine to canine. The length is normal, the CJ is normal, so we have a diagnosis of dentoalveolar extrusion. This is the most difficult diagnosis for the restorative dentist to treat. And routinely, we have 3 treatment options for the patient with dentoalveolar extrusion: orthodontic intrusion, functional crown lengthening, or restoring at an increased vertical dimension. Top is normal, bottom problematic. The teeth look a little short in this patient, and she has gingival display. So we ask the questions. That's normal, and that's normal. Now we're to a problem. We've got a short tooth, and there's only 3 reasons a patient can have a short tooth. It's either anatomically short, like a microdont, or there's wear, or there's altered passive eruption. So we ask question number 5, which is a CEJ, and in this patient, you can't feel it. So if you have a patient that has a short tooth and you can't feel the CEJ, the diagnosis is altered passive eruption. And once we call it altered passive eruption, the treatment is always aesthetic crown lengthening. So a patient can have as many diseases as she pleases. And there's no rule against having more than one of these global diagnoses at a time. So let's look at this more complicated patient. There's the problem, there's a problem. That's actually okay. There's a problem, and there's a problem. So when we look at the numbers on this patient, she's got 4 things going on. Vertical maxillary excess, short, hyperactive upper lip, and altered passive eruption. This is a very complex patient. And now that we've named what she has, named the conditions, it's easy to sequence her treatment plan. All right, so the 5 in the 4, 5, 6 are the 5 core questions. The 6 are the 6 things that we can do to fix a patient. And Jeff and I call them the 6 tools. We actually only have 6 ways to move the teeth and gingiva into the correct positions. And here they are. The first 2 are the perio tools. And we can either add tissue with a graft, or we can subtract tissue with crown lengthening. The second tools are the intrusion and extrusion tools that the orthodontist offers us. So that's 4, 3, and 4. And the 5th one is surgery. And that would include orthognathic surgery, extraction, and implants. And the 6th tool is plastics. And plastics would include Botox, filler, and plastic surgery procedures. So at the end of the day, we only have 6 ways to fix a tooth gingiva problem in any patient. So we have 4 diagnoses, we've got 5 questions to lead us through the diagnosis, and we've got 6 tools to correct any discrepancy that we see. So let's finish up with a patient. Let me introduce you to Lynn. Lynn's 25 years old. Her chief complaint is, I don't like my smile, I think my teeth are short, and I don't like the gum that I show. All right, so we've got several chief complaints for Lynn. So let's go through and ask and answer the 5 core questions so we can make a global diagnosis. So we measure her midface and lower face, and they are essentially 1-to-1. We measure her lip, and it's only 19 millimeters long, which is a little short for her. We measure her lip mobility, and it's 9. That's a little excessive. So she has a short lip and a hyperactive upper lip. We look at her gingival line, and we draw the line from canine to canine, and we see that it's concave. So now we have another problem with this patient. We measure her central incisor, and it's only 7 millimeters long. And finally, we feel for the CEJ and the sulcus on this patient, and we can't feel it. So now we have 4 global diagnoses. The top number is correct. The face height is okay. That leaves us with these 4 numbers, which leads us to the 4 global diagnoses on this patient. She's got short and hyperactive upper lip. She's got dentoalveolar extrusion of her maxillary anterior teeth, and she's got altered passive eruption. The next thing that we do in our system is we then gather what we call regional diagnoses. And regional diagnoses are all those things that we've always collected: periodontal charting, pulp testing, caries, cracked tooth. Those are all regional data. And in her, she's pretty healthy. So there's our problem list. We've got 3 problems from our global diagnosis and 1 problem from our regional diagnosis. So now we're ready to make a treatment plan. So in this patient, we're going to do orthodontic alignment and intrusion of the maxillary anterior teeth. We're going to do aesthetic crown lengthening, porcelain veneers, and then finish up with a protective device. So here we are. The patient is now in ortho, and we're moving the teeth into the correct positions so that we can make anatomically correct anterior teeth with our porcelain restorations. We're then going to the aesthetic crown lengthening procedure. And you can see in these patients, they heal up very quickly. This is the patient at 1 week post-op at suture removal. This is the patient healed up very nicely at 3 months. And you can see that we've gone from 7 millimeters pre-op to 7 to 9 millimeters post-op. So now we're ready to do our restorative dentistry, put our restorations on. And our goals are two in this patient. Our first goal is to make her beautiful aesthetically, and our second goal is for this to last a long time. So here's our patient at a 17-year post-op with a pretty smile, doing very well at 17 years. But you say to yourself, yes, but she still looks a little bit gummy to me. And what's the reason? Well, let's look back at our global diagnosis. If you remember, the face height was normal, so we can get rid of that. So what did we treat? We treated the gingival line problem with orthodontic intrusion. We treated the altered passive eruption with aesthetic crown lengthening. The one thing we didn't treat was her upper lip. So if Lynn was really unhappy with her presentation, we could give her Botox and or filler to take care of that final piece of the puzzle. So we have 4 diagnoses, we've got 5 questions, and we've got 6 tools. It has indeed been a pleasure for me to be able to share this information with you. This is my contact information, and if there's any time you need to contact me, please feel free to. Thank you very much.